Approach to tremor. Tremor, the most common movement disorder, has many causes and requires close observation to accurately diagnose. An anxious 60-year-old woman with no past medical history presents to the clinic with 3 years of progressively worsening and disabling tremor without other neurological symptoms. Her mother has a similar tremor. Caffeine and stress worsen it. Alcohol improves it. She denies drug use. On examination, she has a regular vocal tremor when holding vowel sounds. She has no rest tremor, rigidity, or bradykinesia. She has more action than postural bilateral upper extremity tremor. She has no gait abnormalities and the rest of her exam is normal. What is the likely tremor diagnosis and approach to her care? Tremors are classified based on their state, at rest, with posture, or on action. They may also be rhythmic. Careful clinical history and thorough neurological examination form the basis for generating a differential diagnosis and management plan. The history and examination drive ancillary testing and treatment plan. Important components of a detailed history include time course, precipitants and palliators, affected body regions, and other symptoms like dexterity loss, muscle cramping, or gait issues. A comprehensive history should also include past medical, family, medication, and social histories, including caffeine, alcohol, and drug consumption. A thorough neurological and movement disorder examination follows, beginning with observation of the patient at rest to assess for resting tremor. Head tremor, directionality, and dystonic neck posturing are assessed by observing as the patient counts backwards. If not evident during history taking, asking the patient to extend a vowel sound can elicit oscillatory changes in volume or pitch. Slightly opening and closing the jaw and evaluating the tongue at rest and with protrusion allows the examiner to visualize chin and tongue tremors respectively. Next, assess for postural tremor. Have the patient extend the arms outward and in wing beating positions. Dystonic components to tremors are identified by null points, a position at which the tremor is lessened. Immediate bilateral postural tremor is often seen in enhanced physiologic and essential tremors. Re-emergent tremors, resting tremors emerging after a short delay with outstretched arms, are seen with Parkinson's disease. Finger-nose-finger maneuver can assess for dysmetria and action tremor, of which the latter has the largest amplitude in essential tremor. Assess for rigidity through passive joint movement and bradykinesia, or decrements and pauses in movement, through repetitive fine motor tasks. Having the patient stand still can assess for orthostatic leg tremor. Different tasks clue the clinician to the tremor type. Spillage of water while pouring is often seen in action tremors, such as essential tremor. Posturing and tremor during a specific task can suggest a focal dystonia, and drawing a spiral can help with diagnosis based on its size and shape. Assess gait for subtle pyramidal, Parkinsonian, or cerebellar features. Finally, psychogenic tremor can be distinguished by distractibility and entrainment, or a matching of the frequency and amplitude of the tremor elicited by having the patient perform rhythmic, repetitive movements with an unaffected extremity. Our patient has essential tremor, a bilateral upper extremity predominantly action and postural tremor. The lack of irregularity, a null point, and bradykinesia preclude dystonia and Parkinsonism respectively. She was treated with propranolol and subsequently primidone with minimal improvement. She later underwent bilateral ventral intermediate thalamic nucleus deep brain stimulation with marked improvement in tremor postoperatively. For more information on tremors, clinical presentations, and management, please see the course resources.